This is the Mechanical Care Forum, episode 327 of Season 8, and we're continuing our discussion with Dr. Chris Showalter of MAPS, Maitland Australian Physiotherapy Seminars. We talk about key principles within the Maitland approach, orthopedic manual therapy associations, our challenges related to promoting our value in the public, and more, this week on MCF. I'm Jason Ward, and this is the Mechanical Care Forum. Think of it as your weekly dose of inspiration, information, and entertainment, where we interview leading clinicians, instructors, researchers, authors, practice owners, and more, all for the purpose of sharing experience for improved patient care. This episode of the Mechanical Care Forum is free, and it's brought to you by myself and a small team to help you along your journey. If you'd like to show your support, you can do so by making a small donation or even a big fat one. We'll gladly take any amount, and we use it wisely to continue to produce this great content. Go to mechanicalcareforum.com to show your support. Hey everyone, and welcome back this week for the conclusion of my interview with Dr. Chris Showalter. More important and relevant discussion on manual therapy and the approach which he's been teaching for decades. That coming up in just a moment. But first, don't forget to sign up for my free weekly email update if you'd like to get notification of new episodes and keep up with all that's happening with MCF. You can sign up at mechanicalcareforum.com. So do you include an assessment of the thoracic spine with a patient with lumbar, hip, or lower extremity complaints? If you do, how far into it and in what way do you assess that region of the spine? Are you seeing any patients respond with symptoms in the lower half through movement or procedures targeted at the thoracic spine? This is just some of what we addressed in the most recent session of Case Conversations with Robert Metcalf while highlighting a 55-year-old female with bilateral hip and groin pain. If you wish you had other like-minded clinicians, or even better yet, some of the best mechanically trained experts to serve as your virtual mentor, check out Case Conversations at mechanicalcareforum.com. In the next few weeks, for the month of November 2020, on my new podcast, Inside the Science, we're highlighting 4 more studies through an audio summary, the Cliff Notes, so to speak, and we're discussing the paper with the authors themselves. Studies like consistency of orthopedic special tests of the shoulder and the well-known XBOS, or Extremity Pain of Spinal Source, paper with Richard Rosedale, and 2 papers with Nikolai Bogduk, the cervical discs as a source of neck pain and analysis of the evidence, and cervicogenic headache, an assessment of the evidence on clinical diagnosis, invasive tests, and treatment. With Inside the Science, premium subscribers receive the full discussion, an infographic, and a PDF, and access to a community of other equally devoted clinicians who realize we all have the responsibility to keep up with the literature. So if you'd like to improve your performance and stay up on the current science, perhaps better than you ever have before, check out Inside the Science, which you can also find at mechanicalcareforum.com. All right, we heard from Dr. Showalter last week on his professional journey, his exposure to Jeffrey Maitland, Robin McKenzie, and others, and his take on what sets MAPS, the Maitland Australian Physiotherapy Seminars curriculum, apart. So we'll pick up there and continue with part 2 with Dr. Chris Showalter. Enjoy. The misconception related to that then is what? What do people understand incorrectly about MAPS?
Find where it hurts and push on it.
Yeah, got it.
Right? Oversimplification, right?
Yeah.
Yeah, because the assessment is, and our assessment form is very similar to a McKenzie assessment form. Incredibly similar, okay? We're teasing out the same things. Irritability, how much activity causes, how much symptom provocation, and how long does it take to settle down, right? Yeah. That's a key component in Maitland.
Yeah.
He first wrote about it in the late 60s, early 70s, right? So the similarity between McKenzie, Mulligan, and Maitland is going back to the story of Abraham. Yeah. We all have the same base thought process going on. Uh-huh. We just practice our art in a slightly different way.
Yeah, it's fascinating, isn't it?
Let me ask you a question, Jason.
Yeah, sure.
Now, so as I said, I did some work with Robin McKenzie back in the late 80s. Many of you listeners weren't even born then.
Yeah. I
have taken a couple of McKenzie courses a long time ago. How much emphasis does current-day McKenzie training in the U.S., because you're U.S. cert McKenzie, right, Jason?
That's right.
How much current emphasis is put on passive physiological movements, for example?
Yeah, it's certainly not where we start, of course. We start with patient-generated movement.
Right.
Yeah. Perhaps there is a piece, but we don't pass judgment on what that means. We just use it as a comparable sign, perhaps.
Sure.
To then see, is it rapidly changeable or not. And
sure, absolutely. But so we don't afford. So I suppose this is a difference between Maitland and McKenzie.
Okay.
All data is important in Maitland, right? The active physiological and symptom provocation, the passive physiological and symptom provocation, and the passive accessory and symptom provocation. Now, passive physiologicals in Maitland are pretty useful techniques. I mean, in the cervical spine, they've got a sensitivity of 90 for ruling out hypomobility or stiffness. In the lumbar spine, they have 92. Sorry, that's for passive accessories. The PIVMs in the lumbar spine, passive physiological flexion extension, have sensitivity for ruling out hypermobility of between 95 and 98, depending upon the paper. That passive physiological movement, and I know, Jason, that you know this, because I know that you use lumbar rotations on your McKenzie-style treatment patients, right?
If the indication is there you're talking about to flex rotate.
Yeah, so lumbar rotation mobilization, right?
Sure.
I'm not talking about active physiological. I'm talking about when you're doing passive work with the patients, right?
Sure.
So when you do your McKenzie rotation, which is, and we've all got the same rotation. It's the same thing. It goes back to Hippocrates and the Turks and the early Chinese. There's no new real way to rotate the lumbar spine. We all use the same thing. Bottom leg straight, top leg bent. Pull that arm through, rotate from the top, facet locking from above, ligamentous locking from below using the pelvis and deflection and extension. Try and focus that rotation to that segment, right? So if we know that passive physiologicals in the lumbar spine have a high sensitivity, 95 to 98, for hypomobility, then we can use that information and use that passive physiological movement to help properly set up that lumbar rotation to give it a better opportunity at a better outcome based on our clinical intent. Does that make sense?
Yeah, no, it does. And so perhaps there is a bit different way that we might rotate, but that's kind of beside the point. The point is that
you do the flexion rotation with knees up. Oh, I get it. I know that.
Yeah. Excellent. So you've spoken on a few occasions regarding the research, and that maybe is an emphasis of some of the leaders within MAPS right now is to establish perhaps some evidence to refute or support. Can you speak on what kind of studies have been shown? Is there reliability from inter-rater perspective, and is there efficacious cost effectiveness type of studies?
I get where you're going, Jason. I'd say the first thing about the comparable sign, whether you call it comparable or concordant, I don't care. Yeah. It's a patient-centric response. It's a patient response to movement. We did some of the landmark work on comparable sign a couple of years ago. Chad Cook, myself, and our research group, this is going back to the 2012, 2014 time frame. We found that this within session and between session change in the patient's comparable sign after the second visit has a significant association with outcomes for pain and the ODI, Oswestry Disability Index, at discharge, obviously in low back pain patients. And we also found that a 2-point change or better in pain is associated with a 50% or greater reduction in the ODI. Okay. So if a patient comes in with a 7 out of 10 pain, and we can get it down to a 5 out of 10 by treatment 2, using comparable sign as the guide, they're highly likely to have a 50% greater reduction in their ODI at discharge. The other thing we found that about the comparable sign is that both within and between session changes, so now we're looking at the cervical spine, both within and between session changes in the comp sign predicted success in the NDI, the Neck Disability Index, at 96 hours. And that between session changes in the comp sign were more useful in predicting changes in these patients than the GROC was. So we have a couple of ongoing projects we're looking at the moment that I can talk to you about in generic terms because we're actually still in data collection at the moment, so I won't allude towards the outcomes. But we've got a cervicogenic headache study where we're comparing trigger point dry needling with mobilization. A separate arm of the trial is trigger point dry needling versus manipulation. So we can look at the role of manipulation versus mobilization in the cervical spine for cervicogenic headaches. We have a study that's actually going to be presented at the AOMPT, the AAOMPT virtual conference next month in early November. It's like 3 weeks away or something, right? Yeah. Where we looked at shoulder comparable sign in people with known shoulder impingement syndrome and whether or not the comparable sign is predictive of their outcome. And it is. Those people who have comparable signs have a mechanical problem and they respond to a mechanical style treatment, compared to those people who have psychogenic shoulder pain who don't respond to a mechanical treatment. Why? Because they're not going to respond to a mechanical treatment because it's not mechanical. Mm-hmm. Sometimes research comes down to that sort of, keep it simple, stupid rule. That, rather than getting caught up in, ratios and CIs and things, just look, what is it saying? 30,000 foot level, what are they saying? Oh, yeah. People with mechanical pain get better with mechanical treatment. That's great. Thanks.
Yeah. Chris, interesting research. Thanks for sharing that. You're describing quite a few scenarios where the patient shows a rapid response, even within a session or between sessions, like you mentioned. Are there some conditions that Maitland, the MAPS approach, identifies that are mechanical but don't rapidly change?
Yeah, it's people with irritability, right? Okay, so I see irritability as a pathophysiological condition.
Yeah.
It's a localized and even systemic inflammation at times, okay? Mm-hmm. Pathophysiologically, we can reduce the pain of an irritable right posterolateral herniation at L4-5. We can reduce the symptoms, but it doesn't stick for long because it's not really just mechanical. It's got substantial inflammatory process going on. So then we use all the other tools in our back belt, right? So we've got interferential if you have one. We've got ice. We can go to pharmaceuticals with the physicians if we need be. Be careful recommending, everyone listening to the podcast, be very careful recommending NSAIDs to people because if they abuse them, you're the person who told them to take them, Yeah. So maybe say, hey, go to the CVS pharmacy, talk to the pharmacist about what they think you should use for your low back pain here. Mm-hmm. Yeah, so there are definitely conditions that don't respond terribly well. So we use a mnemonic called SINS: severity condition, irritability, nature, stage, and stability. Okay, so an acute, irritable anything, shoulder, knee, lumbar disc, is a little slower to respond.
Okay.
I'll give you another parallel, Jason, because I think you've got, you clearly have a really strong handle on McKenzie. What I learned from McKenzie was go for the active movement, make the patient independent. What I learned from Jeff Maitland was in the patient who's chronic and they've had this problem for a time, doing an active movement, and I know just how to push the buttons on McKenzie people. It's all about extension, right? Yeah, no, I'm joking. It's not all about extension. I know that. But let's say, for example, it is extension is the movement, okay?
Sure.
That they're limited in. And your intention is to do extension. Mm-hmm. If you get them doing standing extension or prone on the table extensions, if this is a chronic 2-year-old condition with ongoing pain at, let's say, L3-4, okay? L3-4 is hypomobile and the main pain generator. If we get the patient to actively extend, they may or may not be able to get L3-4 to extend. Mm-hmm. The Maitland people like me would say, well, why don't we go in with our hands and move L3-4 in perhaps a central PA, which would enhance extension, and then get them up and reevaluate their active extension.
Sure.
So I use McKenzie every day with patients, but I use it more as the home exercise program once I've restored and normalized movement segmentally such that they can now move as they need to.
Yeah.
Yeah.
So, which brings me to another question that I was hoping that we would have an opportunity to chat about. You mentioned some studies with some arms that included dry needling. You're now mentioning that, hey, the home program might include some principles that are consistent with McKenzie, MDT. What does MAPS integrate well with? From a clinical, practical standpoint, what do you integrate into your treatment that may not be classic or stringent to MAPS or Maitland?
What do I bring into my treatment, which is not classic Maitland?
Sure.
Is that what you're asking?
Sure.
Yeah, I don't like to say always. I seldom say always and never. Yeah. I always perform a MAPS assessment, a Maitland assessment. Okay. Yeah. And then as necessary, I'll use different tools. Treating a patient recently with a horrendous post-op knee limited in 15 degrees of minus 15 degrees extension, okay? soft tissue massage, lots of fibrosis in and around the superior patellar area. So not only can not extend, he also can't flex. Maitland mobilization's got back about 10 degrees of extension, so we're down to -5. That was 3 treatments of heavy extensions, APs over the tibia. Still couldn't get it all with mobilization. Went in and did deep, do you know Syriax friction grip? Do you know that grip?
Sure.
Yeah, deep Syriax friction grip massage as far as I could. My fingers got tired. I don't have any ASTIM authorized, branded, you can't sell this without having done our course stuff. So I used a soup spoon, okay? I used the round end of a soup spoon to do the rest of my deep instrument work in there, and that cleared it out. So, you know, the flexibility of the Maitland approach is you're never wrong as long as you have a reason for what you're doing. You can add in anything you like at any time. You must go back and reassess. What you must do is reassess at least one subjective characteristic. Did the pain change? Does the movement feel better to you? And one objective characteristic. Does it move better? Does it have more range? Does it have better function? Does it feel more comfortable to the patient?
Let's just run with this patient example, if you don't mind. In this patient, because they're with themselves a lot more time in a week than we're with the patient, what was the patient's responsibility? What were you having them do in addition to your soup spoon?
Okay, so my two clinicals for that were the soup spoon, right? The soup spoon got the final bit of the adhesions and fibrosis in there. His situation was he was on his 3rd knee in a 1-year period. He had a total knee arthroplasty. It got infected with MRSA. They replaced it with the interim knee, which they packed with vancomycin. He was on a PICC line for 6 months to knock the vancomycin out of his body, okay? And then they pulled that one and they drilled a new hole down through the tibia. And he's young, he's 62, okay? No one should have to go through this, but at 62, it's hard because they've drilled out so much of the core of his tibia. They're now running out of options if they have to put another knee in, okay? So they put that in, but for the whole time they were treating, and this is lack of laterality of thinking in the profession that we work with, in the medicos sometimes. They were so concerned about the infection and so concerned about the knee not moving that they put him in a 15-degree flexion brace and they kept him there for 6 months and didn't let him move it. And then they changed it out. And what they should have done is a good orthosurgeon on the knee should have cleaned out all that fibrosis in there when he went in to put in knee number 3. But they didn't. So he ended up with me. That's all right. He's fine. In terms of his home exercise program, no soup spoons. He's not qualified. He's only qualified to eat soup with his spoons. I actually had him doing some soft tissue massage with his thumbs. And a little clinical pearl I like to tell when I'm teaching is that I don't like to use free up or massage oils or any of that sort of stuff for massage, because when you then go in to try and mobilize tissue in there, to go deep in, you can't. Your fingers slip off. You have to clean up the area and get the goop off, right? What works equally well, if not better, is talcum powder. If you put talcum powder over the knee joint in question, you can gently do very, very soft palpatory work through it. You can do deep massage work, but you don't slip through it when, for example, you try to get onto the lateral border of the patella and glide it medially. You don't slip over the top of the patella anymore because the talcum powder gives you grip and slip. Just everyone at home, try talcum powder instead of massage oil for a change.
There you go.
So his home exercise, to answer your question, and we're going into hour 3 now, his home exercise is deep soft tissue work to which he can tolerate. First, he cooks it with a heating pad for half an hour. I want the collagen as distensible as possible. And I have him trained to find knots and move them. These are not dry needling. These are not traditional dry needling points. These are pieces of tissue in there which are fibrosed. So that, and then sitting in a chair with his heel on a chair opposite him, with the popliteal fossa pointing down at the floor and free in space. And we started adding weight to it in sitting. And we got up to about 35 pounds of weight. He would sit there, he would heat his knee, do the deep tissue work that he can do competently himself at home, and then put a 35-pound vest, which used to be his running vest when he did triathlons to get fit, put that vest over his knee. So 35 pounds of weight, pushing it into extension.
Yes, very good. Chris, you talked about 3 sessions of your manual skills to get the first 10 degrees of that extension back. Was he
Correct.
applying any type of self-generated, patient-generated overpressure to create any kind of self-mobilization?
After treatment 2, yes. So here's my rule, okay? I never trust them, okay? I trust, it's like Ronald Reagan, trust but verify, okay?
Sure. Okay.
So I'm going to assess them. I'm going to treat them. I'm going to send them home with specific directions. I'm not going to give them a day 1 home exercise until I know how they've responded to day 1. I'm going to bring them back on day 2, find out, because I'm always questioning irritability. How much activity causes how much symptoms, how long to settle down. So I'm going to say, okay, how did you feel after you left the practice yesterday? How did you feel like yesterday evening? How did you sleep last night? How did you feel when you woke up this morning? How does it feel now? If it's better, then good. Now you're engaged. Now I can teach you how to do stuff at home. I can teach them graded mobilizations, etc. What I had him doing day 2 at home was leaning his body weight over his knee in that same scenario where his knee is sitting with the heel on a chair facing him and the floor is underneath, an empty space underneath his posterior knee joint, and he's pushing his femur down towards the floor as much as he could stand.
Right. All right, so let's shift a little bit more from the perspective of orthopedic manual therapy. You have some significant roles that you're playing within that group, whether it's AOMP specifically or just in our profession as a whole. Talk to us a bit about the importance of proposing or promoting ourselves as that go-to clinician that people out there in the general public with musculoskeletal symptoms should be seeking first, or should we? And just what are your views overall for us to be, well positioned within our markets as that expert? That's a good place to start.
It's of paramount importance to the survival of our profession.
Mm-hmm.
Yeah, physical therapy is kind of the handmaid of the physicians. For many years we've done what the physicians want us to do. Ask your listeners: do you live in a direct access state?
Mm-hmm.
Does that mean you'll get paid for seeing the patient without a prescription from an insurance company? If it does, then you've got true direct access.
Mm-hmm.
Like a lot of us, me in New York and my other practice in Delaware, you don't get paid without a prescription from a physician. Yeah. So it's not about money, it's about autonomy.
Yeah.
Harvard University did a study a number of years at the MBA school, Master of Business Administration. When you hire an employee is interested in salary and benefits. But what they value above salary and benefits is autonomy, okay? The ability to do things their way within the paradigm of working for General Electric or Honeywell or whoever it is. They're going to be a team player. They just don't want someone breathing down their neck all the time. Yeah. And it's that autonomy that we need to try and get better at here in the US. Through my work with iFont over the years, I used to be the iFont rep for the US from 2000 to 2009. I speak Australian accent. That makes sense for me to be the iFont rep, I suppose. But from 2000 to 2009. So, for example, in the Netherlands, if you're fellowship level trained, a fellow of the academy, you actually get reimbursed at a different level than a non-fellow from the insurance companies because their socialized medicine system recognizes the benefit of higher quality practitioners. And not only do they pay for manual therapy, they even pay more if you do like a TENS machine or an ultrasound or an interferential. You get paid a higher differential because of the quality of your training and the quality of what you're giving. It's so important that our profession, particularly orthopedic manual therapy, which is obviously you and me and your listeners based upon the style of podcast that you do, it's so incredibly important that we don't be afraid to stand up and wave our flag. And like Tim Flynn at EIM says, we're better, we're faster, and we're not going to kill you. Yeah.
Mm-hmm.
So that's why, I'm very proud of the American Academy and the work of Elaine Loneman, who you had on recently. I saw on a podcast. I didn't have a chance to listen to it yet, but she's a wonderful president of the Academy doing fantastic work. The Academy and myself and others became concerned about our autonomy as the orthopedic manual therapy experts in the US. So certainly in the PT realm. So the Academy, in coordination, founded a group called the Foundation of Orthopedic Manual Therapy, FOMPT. So that foundation has the mission statement, basically, to conduct and disseminate research on orthopedic manual therapy, promote orthopedic manual therapy to our colleagues, to our PT colleagues, our physician colleagues, to insurers, and to the public at large, so that people understand what orthopedic manual therapists do. One of the other things that the foundation did was set up ACOMT, the Accreditation Council for Orthopedic Manual Physical Therapy Education, which it was one of those situations, kind of like being in the army, when you're standing there and they say, men, women, we need someone to step forward and take a dangerous mission. And you're just standing there and you swear, what do you mean? Why am I here? All these people stepped back. Everyone else stepped back. I didn't step forwards. Anyway, I got asked to be the inaugural chair of ACOMT, and we've been in existence since December of last year. And what we're doing, we're the accreditation body for fellowships that wish to be recognized by the Academy. Those fellowship programs need to make the decision if they're going to go with ABFRE, the American Board of Physical Therapy Residency and Fellowship Education, which reports to APTA, or go to us, which reports to the Foundation and AOMT, or do both. Some of them do both. There's a number of programs that do both. So, the genesis of that was because what was happening at ABFRE, some changes that were occurring there were making it difficult for our programs to comply with IFOMT, the International Federation of Manipulative Physical Therapists, of which the US is the member organization. So, apolitical, just a genesis to do things that were better for our people.
We've talked about this issue for a long time within our profession of how can we position ourselves. So we obviously have these challenges. In light of us knowing that we've needed to, continue to promote us as a best first choice, why do you think we haven't progressed? A patient out there who's dealing with a musculoskeletal issue could go to a chiropractor, could go to an acupuncturist, a massage therapist, a personal trainer who has helped someone else, do some strengthening, and that therefore they're now an expert on back pain because they've helped a client of theirs before, get to moving, and that's caused them to become, less symptomatic. A doctor, an orthopedist, a neurosurgeon. We have such a large group that's going after that same patient. Or what is it at the root of improving, our position for that patient?
So I think that the failure begins at the individual level. That the individual PT who practices regular straight PT and the orthopedic manual therapist PTs, they need to tell everyone they meet. And they do that with their patients. They demonstrate that to their patients with their hands and with their interventions and with the outcomes the patients get. We need to tell everyone. You need to tell everyone meet at a cocktail party. You need to tell people we're frontline. We're trained. Most of us have now got DPTs or transitional DPTs, right? Look, here's the deal. Sorry, that sounds like Joe Biden. I don't mean to be. Sorry, I'm not being political. But I will say something controversial. The best trained knee surgeon in a socialized medicine country like Australia or Canada probably makes $700,000, maybe $800,000 a year. That's a 60-hour week. That's seeing patients, doing surgery, doing follow-ups, checking on patients on Saturday at the hospital. Okay, an orthopedic surgeon in the United States, they start on about $650 when they graduate, and depending upon how many surgeries you do, the numbers are like it's like the NFL. It's like Kobe Bryant. It's like it can be $1 million, it can be $2 million, it can be $5 million a year.
Yeah.
You get these patients who say, I went to see the physician who does I'm in the New York area, so physician for the New York Giants. Oh, did you see so-and-so? No, I don't know who that is. Oh, okay. You saw one of the other guys in the practice who works for the guy who sees the New York Giants, right?
Sure.
So it's the Academy, and that's what the foundation is about, that encompasses ACOMT. The foundation includes some great people, Tim Flynn, Deirdre Tian, Bland O'Connor, and Steve McDavitt, and Catherine Patler, and who's associated with the University of St. Augustine, and Stanley Paris, obviously. People who are trying to get the word out. It has to be grassroots. Every PT who does orthopedic manual therapy needs to advocate for it. They need to warn people about potentially hazardous procedures which are occurring elsewhere. We'll leave it at that. It needs a groundswell. I know that Tim Flynn and John Childs and Julie Whitman banged their head against the wall of insurers for years, saying, look, here's the stats. Here's what orthopedic manual therapists can do. You probably know that Rodriguero article from about 2016, I believe, in terms of quality of care was something like 16,000 patients in photo, right, with multiple different orthopedic diagnoses, primary diagnoses. So fellowship-trained therapists did better than regular therapists who did better than board-certified therapists. Board-certified therapists had the lowest outcomes, and the outcomes they measured were return to function, minimized number of treatments, minimized cost, increased GROC, and increased satisfaction and function. That stuff needs to be presented to people. But I know that Tim and the others from EIM did that years ago, and they just banged their heads against walls. And the insurers go, yeah, okay, great. But you know what? You guys don't have the advocacy, okay? Let's be honest, okay? How many people at APTA work in the area of payment advocacy? I believe it's one. I might be incorrect, okay? Mm-hmm. However, other professions that you mentioned, like medicine and chiropractic and others, have very, very strong advocate arms. Mm-hmm. They pay a lot of money in PAC money. They get a lot of doors open to them to go in and discuss their situation, right? Mm-hmm. Athletic trainers in the last, 5 years have gone from not really having a code in the CPT, and now in the CPT they have athletic trainer evaluation and athletic trainer reevaluation, right? Mm-hmm. And CMS is looking at that. And I'm not sure, and I'm not politically involved in that, and I don't know where all that is, but I know there's been some fighting going on between APTA and athletic trainers. Athletic trainers are upgrading new athletic trainers are coming out with a master's with an opportunity to do a doctorate, I think. Mm-hmm. Okay. We've upgraded from our original degrees to doctoral degrees and transitional doctoral degrees. But at the same time, that also brings to the fore, okay, so now I'm a doctor of physical therapy and I've got a patient coming in. So now that I'm trained in it, now I have a responsibility to do cardiothoracic, I need to do pulmonary screening, I need to do integumentary screening, I need to check if they're a smoker, I need to start advising them about giving up smoking, alcohol abuse, illicit drug abuse, psychological problems. I need to start screening those so that I can inform my colleagues in the other professions. And it's not all about money, but guess what? I don't get paid for that, okay? We have 3 different complexity codes in PT now, okay? But they only pay for the lowest complexity. Mm-hmm. So what does that do to the PTs in the field? They say, well, I'm not going to do all the work to identify a moderate or significantly complex patient if I'm only going to get paid the basic evaluation. So I'll just do the basic evaluation for the purposes of that, right? And what does that mean? That means that PTs go into the bucket of, well, they're not really very good at recognizing complex situations. Mm-hmm. For years, I've been saying, when you look at a patient and they've got pain into the posterolateral right thigh, okay, the low-hanging fruit, the easy diagnosis code is what? Sciatica. Sure. Right? Is that descriptive? Is it accurate? Did you do a neuro exam on them? Do you have any evidence for nerve root compression, nerve root irritation? If you do, then that's what it should be documented as. Because if we take 12 treatments to treat someone which we've called sciatica, when in fact they're multi-level disc herniation, multi-level neurodynamic issues, multi-level lack of muscular facilitation control, and deep multifidus, which is turned into well-marbled Kobe beef with lots of fatty infiltrate in it, right? When we take 12 visits to treat a sciatica and we don't give them the appropriate diagnosis code, when we're compared to other professions who say, yeah, well, it took me 12 treatments to help that patient, but they had a nerve root impingement, and that's defined by the DTRs and changes in myotomes, right? So sometimes we're our own worst enemies and we shoot ourselves in the foot. Everyone has to do the best they can for their patients, but we have to tell the rest of the world too.
Yeah, it's a tall order, a challenging, topic, and one that we've been wrestling with for a long time. But I just was curious of your thoughts, so thanks for sharing that. Let's talk for a moment about the individual professional development, whether that be in conferences and courses or just your own experience over the years. Chris, what have you found that has helped you develop the most?
So there's no doubt that working with a competent, experienced clinician with more experience than you is a phenomenal part of a learning journey for any therapist.
Mm-hmm.
And I don't care what brand of orthopedic manual therapy they do, what religion they prescribe to. It's the more you can see of what other people can do, the more you can take positives and recognize things that you can incorporate into your practice without leaving your own paradigm behind. You don't have to become a McKenzie therapist or a Maitland therapist or a Paris or a Carlton-born therapist. You can adopt the best of the rest if you like. Okay, that's fine. So, ongoing learning is critical for us as clinicians, continuing professional development. Because I teach so much, and I teach a lot in the United States, and I also teach internationally. So, as I said, I haven't been to a McKenzie course in years because I'm generally teaching on that weekend. But the thing is, go to the big conferences. And my favorite conference is AOMT, the American Academy of Orthopedic Manual Physical Therapy. It's on in a couple of weeks. It's a remote conference this year, which is terrible, but it's the best we can do in the time of COVID.
Yeah.
But the things that you take away are interacting with those experienced clinicians. Whether they're gurus or not is not important. Just getting other people's viewpoints, seeing the way they do things. And a lot of the interaction is over a beer in the bar, You get more in the bar, more information in the bar than you do in the big session when the panel's being moderated, right? Yeah. So, I highly recommend, find a conference that works for you. Find the McKenzie conference, go to the AOMP conference, go to conferences where you're exposed to other people's thinking and see if you can incorporate some of that into what you do.
Yeah.
That makes all of us a better clinician.
Yeah. Chris, parting words of advice. If you had to look back at yourself 25 years ago, knowing what you know now, what kind of advice would you give yourself? Oh, dear.
30 years ago, I didn't think I was going to be teaching manual therapy. I never really I want to be a manual therapy teacher. Do you?
Mm-hmm.
Oh, why would you want to do that? It's hard enough being a clinician 6 days a week, right? So, parting words of advice. I would have done my doctorate earlier on. I would have done my DPT earlier on. I was busy building maps in the late 90s and early 2000s. I finally did a transitional DPT. I finished in 2018. And, understanding just for the younger members of your audience, there were no MRIs when I graduated, okay? Or they were research tools, and no one had access to get a patient into an MRI. Mm-hmm. CTs were expensive. CTs, as you know, give people a lot of ionizing radiation, so you have to use them judiciously, right? So, I would have gotten on more of I got a lot from my DPT, particularly in changes in pharmacology since I graduated, changes in terms of diagnostic imagery, like I just spoke of, changes in evidence-based practice. 10 years ago, I used to stand at lecture in the back of the hall at big conferences and confidence intervals. I got to look that up. I'm not sure what they're talking about there. Mm-hmm. I just want to know the p-value. Is it better than 0.05? If it's better than 0.05, it's good. I'll listen to the study, right? And we know that's not enough. So, that would have been my advice. If you're going to, I love to teach. I love what I do. I love our profession. As you can tell, I'm an advocate for our profession, and I do a lot of volunteer work for our profession in the academy, as well as ACOMT, etc. So, I try to teach my children. I got kids who are 22, 20, and 18, right? And one of them has a very, very linear perspective of what she's going to do. She's in college overseas. I'm going to do this, then I'm going to do this, then I'm going to do this. And I try to impress upon her, there's nothing wrong with having a plan, but understand that life or karma or God, your choice, attribute it wherever you like, is going to make you go on a left turn. And you had no intentions of going there. And you may have even resisted it. But as you go forwards, you realize and you look back that, oh my goodness, I got to where I am today because of that unexpected left turn, which I fought at the time. So to a degree, it's go with the flow. I'll leave you with a song by Darius Rucker, This. Do you know that song?
I don't.
Everyone go to Spotify or YouTube and see Darius Rucker, and the name of the song is This. All the things that have happened in my life that brought me here to this.
Yeah. Well, Dr. Chris Showalter, sorry for the misrepresentation earlier.
Oh, I'm horrified. Get me off your show. Oh,
that's all right.
Such disrespect.
But I do want to say thank you. Thanks for what you do from an AOP perspective, but as well as within MAPS, but also just within promoting ourselves as a go-to person for those people with musculoskeletal symptoms. Thanks for joining the podcast, and thanks for sharing your views today.
Hey, thank you, Jason. It was fun. We'll do it again some other time, okay? Call me back in 6 months.
There you go. Fantastic.
And there you are with episode 327. I'm super grateful to Dr. Showalter for his willingness to join us and for his similar focus on patient-centered care, empathy, and interest in advancing all of us to a better position for the benefit of the patient. What do you think about Chris's attitude about waiting to start a patient on a home exercise until the second visit to know how they responded to the initial intervention administered day one? Do you agree or disagree? So have you had any exposure to MAPS or the Maitland approach? Do you use it regularly in your assessment and treatment? If so, what aspects of it or in what way? I'd love to hear your thoughts and your experience, and you can share your comments on the page of this episode, mechanicalcareforum.com/podcast/327. And while you're there on my site, feel free to check out all the past 326 episodes with all sorts of experts and leaders. You can also check out my resources, specifically Case Conversations and my new podcast, Inside the Science. It's all there at mechanicalcareforum.com. All right, I wish you a great week with your patients this week. At the individual level, you promote yourself and your skills and share what those in your community need that you can provide. And join us right back here for more next week with sharing experience for improved patient care. The views and opinions expressed on this podcast are those of the founder and host, Jason Ward, and his guests, and may not be those of the McKenzie Institute International. The content here is independent of the McKenzie Institute International and is not associated with its educational program.